In this presentation, the techniques for the intramedullary fixation of a proximal femoral fracture will be demonstrated using the Retrograde Antegrade Femoral Nailing System, or RAFN. Clinically, each step of this minimally invasive procedure is verified under image intensification. Nails are available in diameters from 9.0 to 15.0 millimeters, in lengths ranging from 160 to 480 millimeters, and are universally designed for retrograde and antegrade insertion in the left or right femur. The nails are cannulated to enable insertion over a guide wire or reaming rod for reamed or unreamed techniques. These nails are designed with an anatomic antero-posterior curvature for ease of insertion and extraction. Multiple locking options for static, dynamic, standard and spiral blade locking are possible. It is also possible to choose between spiral blade locking with one spiral blade and one locking screw for retrograde nailing only, and standard locking with two locking screws intraoperatively. In this presentation, the procedure will be demonstrated using the antegrade surgical approach, the reaming technique, and standard proximal locking with two locking screws. Upon completion of this exercise, you should be able to identify the clinical indications and contraindications, describe the correct patient positioning, identify the correct entry point for antegrade nailing, and explain the steps used to perform the surgical procedures. Indications for the use of RAFN nails in the antegrade procedure include cases where there are fractures in the femoral shaft 32A, B, C, ipsilateral hip shaft fractures, ipsilateral femur tibia fractures, femoral fractures in multiple trauma patients, fractures in the morbidly obese patient, fractures in osteoporotic bone, impending pathologic fractures, and malunions and non-unions. Contraindications for the use of RAFN nails in the antegrade procedure include cases where there are fractures distal to a hip implant, polytrauma patients in which early nailing is not recommended because of a critical status, and severely deformed femoral anatomy. The patient is positioned in either the lateral decubitus or supine position on a fracture or radiolucent table. In the lateral decubitus position, the patient is positioned lateral with the ipsilateral arm in an arm sling. Padded cushions are placed under bony prominences. In the supine position, the upper part of the body is abducted approximately 10 to 15 degrees to the contralateral side, or the affected leg is adducted by 10 to 15 degrees to allow for unimpeded access to the medullary canal. The image intensifier is positioned to enable visualization of the proximal femur in both the AP and lateral planes. The unimpeded movement of the C-arm is verified before draping to ensure the efficacy of intraoperative radiographic imaging. The instruments for preoperative planning include the radiographic ruler, length 475 millimeters, and the radiographic ruler for nail diameters, length 365 millimeters. In the clinical situation, the image intensifier is positioned for an AP view of the proximal femur, and the long forceps is used to manipulate the radiographic ruler for nail lengths. The ruler is held parallel to the femur on the lateral side and at the level of the femur. The ruler is positioned with the end at or just below the level of the tip of the greater trochanter, and the skin is marked on the lateral side. The image intensifier is repositioned toward the distal femur, the proximal end of the ruler is aligned with the skin marking, and an AP image of the distal femur is taken. The fracture reduction is verified, and the required nail length is read directly from the ruler as it appears on the radiographic image. As an alternative, the nail length can be determined by using the previously described steps on the uninjured leg prior to draping. However, it is unsterile. It is recommended to treat all fractures with the longest nail possible, taking into account patient anatomy or previous implants. dynamization must be taken into account when determining nail length. The dynamic locking option allows 5 mm of travel, therefore a shorter nail should be chosen. The nail diameter is determined by repositioning the image intensifier for an AP view of the femur at the level of the isthmus. The radiographic ruler for nail diameters is placed on the narrowest part of the isthmus, and the estimated diameter is measured from the circular indicator that fills the canal. The entry point for the retrograde antegrade femoral nail is in line with the medullary canal in the AP and lateral views. The entry point is posterior in the proximal femur in the piriformis fossa, but varies with patient anatomy. The entry point determines the optimal anatomic position of the nail in the medullary canal. The RAFN nail insertion should not be attempted without the identification of the correct entry point. The instruments for guide wire insertion include the guide wire, diameter 3.2 mm, length 400 mm, the protection sleeve 13.0 for expert RAFN, Antegrade with quick coupling, the multi-hole drill guide for protection sleeve 13.0 for expert RAFN Antegrade, the handle with quick coupling, the drill bit, diameter 13.0 mm, cannulated, flexible, the holding forceps for Synream reaming rod, diameter 2.5 mm, the reaming rod, diameter 2.5 mm, with ball tip, length 950 mm, the universal chuck with T-handle, the Synream flexible shaft, the Synream reamer heads, diameters 8.5 mm to 16.0 mm, increasing in increments of 0.5 mm, and the collection tray. The guide wire is inserted and its optimal position is confirmed under image intensification in both AP and lateral planes before continuing the procedure. The handle, protection sleeve, and the multi-hole drill guide are assembled, and the assembly is inserted over the guide wire through the incision to the bone. The multi-hole drill guide can also be used to correct a misplaced guide wire. To do this, the drill guide is inserted over the first, incorrectly placed guide wire, which is kept in place. A second guide wire is then inserted in the correct position, and the first incorrect guide wire is removed. However, in this presentation, the guide wire is in the correct position. The multi-hole drill sleeve is removed. The cannulated drill bit is passed over the guide wire and through the protection sleeve to the bone and drilled to an approximate depth of 10 centimeters. The cannulated drill bit, the guide wire, and the protection sleeve are removed. The reaming rod is passed through the universal chuck with T-handle and the reaming rod inserted into the medullary canal. The tip of the reaming rod is positioned under image intensification in both the AP and lateral planes in the center of the distal femoral condyle. This will prevent a valgus or varus deformity at the fracture zone. The approximate depth is gauged by placing a guide wire parallel to the inserted reaming rod at the bone. To begin reaming, the 8.5 mm diameter reamer head is attached to the flexible shaft by inserting the tip of the shaft into the cannulation of the reamer head in the tray. Observe that the 8.5 mm reamer head is the only head that has a cutting tip. The assembly is guided over the reamer rod into the medullary canal. Reaming begins with the 8.5 mm diameter reaming head and is repeated in increasing increments of 0.5 mm until a diameter of 0.5 to 1.0 mm greater than the nail diameter is attained. The reamer is advanced with steady, moderate pressure and regularly retracted to clear debris from the medullary canal. The holding forceps is used to control the rotation and to prevent inadvertent extraction of the reaming rod. The fracture reduction must be maintained and confirmed under image intensification. The used reamer head can be detached from the flexible shaft using the slot on the side of the collection tray. The reaming procedure is repeated until the desired diameter is reached. The reaming assembly is removed, leaving the reaming rod in place. The instruments for antegrade nail insertion are the rod pusher for reaming rod with hexagonal screwdriver, diameter 8.0 mm, the connecting screw cannulated with internal thread, the insertion handle radiolucent, length 100 mm, the screwdriver hexagonal with spherical head, diameter 8.0 mm, with T-handle, length 322 mm, the driving cap with thread for insertion handle, the pin wrench, diameter 4.5 mm, length 120 mm, the combined hammer, 500 grams, the aiming arm, radiolucent for expert RAFN, antegrade for standard locking, and the guide wire. The connecting screw is slid over the rod pusher for reaming rod with hexagonal screwdriver, followed by the insertion handle. The nail is slid over the assembly and the tang of the handle is matched to the notch of the nail. The rod pusher is turned clockwise until the nail is tightened securely to the connecting screw and the insertion handle. The rod pusher is removed. The T-handle hexagonal screwdriver with spherical head is inserted into the insertion handle and turned clockwise to securely tighten the nail to the connecting screw. The nail is manually inserted over the reaming rod and into the medullary canal as far as possible. Note that all retrograde antegrade femoral nails can be inserted over reaming rods. Slight twisting motions assist the advance of the nail into the medullary canal. The passage of the nail across the fracture is monitored under image intensification in both the AP and lateral planes to avoid malalignment and to verify the fracture reduction. The driving cap with thread is manually connected to the insertion handle with clockwise turns and tightened with the pin wrench. The combined hammer is used to lightly hammer the nail until fully seated. The nail is inserted until the proximal end is at or just below the greater trochanter. The radiolucent aiming arm with cam locks is securely attached to the insertion handle by tightening the thumb screw. Note that the insertion depth of the nail should be at the level of the bone. This can be verified by inserting a guide wire through the hole marked nail end on the aiming arm. The nail insertion depth can be adjusted by manipulating the nail to the appropriate depth as indicated by the grooves on the insertion handle. The guide wire and reaming rod are removed. The instruments for antegrade approach, standard locking are the protection sleeve 12.0 8.0, length 188 mm, the drill sleeve 8.0 4.2, the trocar, diameter 4.2 mm, the drill bit, diameter 4.2 mm, calibrated, length 340 mm, 3-flute for quick coupling, the depth gauge for locking screws, measuring range up to 110 mm, the screwdriver star drive T25, self-holding, length 320 mm, and the screwdriver hexagonal with spherical head, diameter 8.0 mm with T-handle, length 322 mm. The lateromedial hole and lateromedial slot are used for proximal locking. The static locking option corresponds to the lower position of the lateral medial slot. The dynamic locking option corresponds to the upper position of the lateromedial slot to allow dynamization of the bone fragments. For immediate dynamization, one proximal locking screw is inserted through the distal hole in the aiming arm. For later controlled dynamization, insert both proximal locking screws. When dynamization is desired, the most proximal locking screw is removed. This presentation demonstrates dynamic standard locking. The green color-coded triple trocar is assembled by inserting the drill sleeve into the protection sleeve, followed by the trocar. The green color-coded three-part trocar assembly is inserted through the caudal lateromedial hole in the aiming arm to the bone, and the camlock lever is closed. The trocar is removed, and the calibrated 4.2 mm drill bit is used to drill through both cortices. The drill sleeve is pressed firmly to the neocortex, and the measurement of the appropriate length locking screw read from the drill bit at the back of the drill sleeve. The drill sleeve is removed. The depth gauge is disassembled into two parts, the sleeve and the slider with hook. The slider with hook is inserted into the protection sleeve, ensuring that the hook is just beyond the far cortex and the locking screw length measurement read. The self-holding star drive screwdriver T25 is used to insert the appropriate 5.0 mm locking screw through the protection sleeve. Note that the groove on the screwdriver shaft indicates the end of the screw. This screw insertion procedure is repeated through the cranial lateromedial hole. The driving cap is removed with the assistance of the pin wrench. The T-handle screwdriver with spherical head is inserted into the insertion handle and turned counterclockwise to disengage the insertion handle and aiming arm. The instruments for end cap insertion are the screwdriver star drive T40 with spherical head, cannulated, length 280 mm, and the guide wire. When bony ingrowth into the proximal end of the nail is of concern, the use of an end cap is recommended. End caps range from 0 to 20 mm in length in 5 mm increments. The guide wire is inserted into the cannulated screwdriver star drive T40, followed by the 5 mm end cap. The guide wire is inserted into the nail recess. The screwdriver is turned clockwise to the stop to insert the end cap. In the clinical situation, freehand distal locking would occur at this stage of the procedure. However, distal locking is not demonstrated here, as the focus of this presentation is the antegrade femoral nailing at the proximal end. The instruments for implant removal are the interlock screwdriver star drive T40, length 377 mm, the extraction screw for tibial and femoral nails, the combination wrench, diameter 11.0 mm, the hammer guide, the pin wrench, diameter 4.5 mm, the screwdriver star drive T25, self-holding, length 319 mm, and the combined hammer 500 grams. Clinically, before removing the nail, all but one of the locking screws are removed. The most proximal locking screw is left in place for the time being. The interlock screwdriver is attached to the end cap and turned counterclockwise to remove the end cap. The extraction screw is manually attached to the nail and tightened with the combination wrench. The hammer guide is manually attached to the end of the extraction screw and tightened with the pin wrench. The screwdriver star drive T25 is used to remove the distal screw first, followed by the proximal screw. The combined hammer is slid over the hammer guide and lightly backslapped to remove the nail. Upon completion of this exercise, you should be able to identify the clinical indications and contraindications, describe the correct patient positioning, identify the correct entry point for antegrade nailing, and explain the steps used to perform the surgical procedures.